Hello, thank you for taking part in this lesson entitled Organizational Strategies. In this lesson, we'll examine the consumer of the long-term care setting, the Affordable Care Act, payers of healthcare, and the regulators of long-term care. Objectives are listed on the next slide. Learning objectives are listed as follows. We'll examine the characteristics of consumers in the long-term care continuum, determine the best ways to improve the effectiveness of the Affordable Care Act, identify critical information for frontline staff regarding payer sources, and critique the various regulators for the long-term care industry. As a current assisted living director and former skilled nursing director, I've spent my entire career in long-term care. The long-term care continuum features short-term transitional care after a major illness or surgery, lifelong care in a nursing home receiving maintenance care, assisted living for those with higher levels of functionality, and group homes for those who may be younger and have disabilities. Some clients are able to receive additional services while in the home. Most clients live in a congregate setting where they receive care from a set of caregivers following a personalized plan of care. All clients are vulnerable adults who must be protected by a highly skilled set of caregivers. Medicare will pay for short-term transitional care stays, while medical assistance will pay for the lifelong care of those who are otherwise unable to afford services in the skilled nursing setting. Elderly waiver will cover those in assisted living who cannot pay privately. Caddy waiver is meant for individuals who are younger and disabled. All settings have their own regulations that need to be followed. In nursing homes, assisted livings, and group homes, they carry separate licensure. In the next slide, we'll discuss how these clients, mainly skilled nursing and assisted living, are affected by other healthcare stakeholders. Assisted living clients and providers of care. Providers include nursing assistants, medication passers, also known as TMAs, nurses, and providers rounding throughout the building. Providers have a massive impact on the care quality this consumer group has. Unlike the current clinic setting, where patients visit for a brief period of time, the assisted living client has staff members available 24/7 to assist with daily cares. Clients get to know the staff on a personal basis. Given the population at risk, there is an increased likelihood for abuse and neglect. The caregivers need to have specialized training to provide high-level geriatric care in this setting. Generally, staffing is a challenge in these environments. Residents will feel a direct impact if even one team member does not show up for work. It takes a well-coordinated team effort to keep these operations functioning. Long-term care costs are astronomical. A private pay bed currently runs at $100,000 per year per room, with costs rising on average about 2.4% a year, and that was from 2012 to 2019. Now, given it's 2022 and the rate of inflation, many private pay assisted livings are actually raising rates by 10% to make up the difference in cost. Each resident might have medical insurance to pay for the cost of medical care, not daily services, but the x-rays, the lab draws, the doctor visits. Residents in skilled nursing, they must have a visit from their provider every few months for recertification. Assisted living residents need to be seen annually for new orders and ongoing care. Given the complexity of the aging population, visits are needed much more frequently. Diagnostics are usually used. For example, the elderly suffering from frequent UTIs have medical conditions that might require lab monitoring. These clients have a plan paid for by Medicare. Medicare right now pays for 80% of healthcare services, while a supplemental plan, if chosen, like Humana, would pay the remaining 20% not covered by Medicare. Unlike the skilled nursing setting, pay for performance does not apply. Residents have a monthly rent payment and a bill for scheduled services, but pay for performance absolutely includes skilled nursing and the hospital. Assisted living clients and suppliers. Supply costs have the potential to affect resident care in several ways. First, if vendor costs rise, assisted livings will need to raise their own costs. Skilled nursing facilities rely on fixed reimbursement from Medicare or Medicaid, which would have to, they'd have to cut from other areas to balance the budget if costs were to rise with no change in that daily rate. Utilizing a purchasing alliance gives companies an edge with pricing, so items are purchased in bulk at a discount. Suppliers are not just those who provide physical items, but also services. For example, a supplier could be those who rotate and take out garbage, provide maintenance, security, or even nursing agency hours. According to Concordance Healthcare Solutions, a reliable supply chain may have a direct effect on costs in healthcare. For example, when a facility has a reliable stock of supplies, they may be able to recruit and retain better because the staff will express being able to perform their jobs efficiently and with greater satisfaction. Assisted living clients versus regulators. In August of 2021, Minnesota enacted a new array of new comprehensive regulations known as 144G. These regulations set the bar high and bring the level of care needed closer to that of a skilled nursing facility. Under these regulations, surveys are conducted every 2 years, and complaint surveys may be conducted as necessary in between. The enforcement of these regulations helps secure the best care for the residents living in a facility. Skilled nursing dollars are tied directly to compliance. A loss of quality or regulatory compliance could result in a loss of Medicare or Medicaid funds. Even worse, disregarding regulations entirely come with substantial penalties and fines. Moving on to the Affordable Care Act. Despite a contentious fight that ensued until the law was passed in 2010, the Affordable Care Act has been a blessing to many individuals. A participant can no longer be denied coverage due to a pre-existing condition, and no longer is there a fear of reaching a benefit limit. The Affordable Care Act has expanded the Medicaid eligibility pool to individuals who are 138% below the federal poverty level. Many other individuals receive tax credits that can go towards health insurance. Healthcare costs have spiraled out of control for years, as we know. This law attempts to address high costs through quality innovation. The quality of care increases when providers are rewarded financially for creating better value. For example, providers need to ensure that a hospital discharge is appropriate before they go through with it. Any readmission within 30 days may result in no coverage to the provider. The Affordable Care Act was written with the consumer in mind. Under the Act, an emphasis is placed on preventative care. Annual checkups, cancer screenings, vaccinations, those are all considered preventative measures to keep the consumer safe. It's not difficult to accumulate high bills when in the hospital for a long period of time. Insurers can no longer view the covered individual as a liability with a coverage limit. The Affordable Care Act has allowed college students to remain on their parents' insurance through the age of 26. This will allow them to continue going through college with coverage to protect them until they start their post-college careers. Through the Affordable Care Act, access to coverage is widened through Medicaid expansion. Those unable to afford insurance prior to the Affordable Care Act may now be eligible for insurance through the health insurance marketplace. Others may be eligible for tax credits, which can be used to fund their health insurance costs. Prior to the Affordable Care Act, hospitals were reimbursed relative to each procedure that they performed. The more procedures, the more money they made. After the value-based model was implemented, hospitals needed to focus on quality rather than quantity. This means if a patient was rehospitalized within 30 days, there wouldn't be reimbursement for supplies used during that time. This resulted in a change in hospitals reinventing their supply chain management. Labor supply chains are now building warehouses and automating them, and the process is benefiting hospitals by eliminating the middleman. The Affordable Care Act has undoubtedly benefited many Americans who otherwise couldn't afford health insurance. Prior to the ACA, insurers were able to deny coverage based on existing conditions or certain or charge certain consumers more money, like if they have diabetes. This was in addition to the lifetime limits previously established. In short, someone else must pay the price when these new consumer protections are enacted. In this case, it's the healthy consumer that must take on the extra cost to keep the overall prices low. In Minnesota, the cost for a monthly premium has increased 84% from 2013 to 2019. What are some strategies to make the Affordable Care Act more effective? Nurse leaders have an opportunity to maximize the benefits of the Affordable Care Act amongst their patients and staff. Consider the patients nurses care for within the public sector. They need to be encouraged to see their physician annually for preventative care. They need to be shown the process of signing up for health insurance through the marketplace. Employers would find it beneficial to foster policies that encourage staff to reach personal health goals. Hospitals need to review policies and update procedures to ensure a safe and effective discharge. Planning for discharge starts on day one. A rushed or ill-planned discharge will place the patient at much higher risk for readmission. What should nurse leaders share with staff regarding payers, like insurance? As a nurse, I've always been more willing to accept change within a facility if I understand the why behind the decisions made by administration. For example, the facility may be pushing multiple admissions per day, stretching staff thin. If I understood the implications of having a low census, I would probably be more apt to support that quick influx of new patients. Income and occupancy are directly related. Income will be low when occupancy is low, and this affects staffing and hours. Payer mix is critical. So patients under our care have different payer types, some which pay better than others. Certain payer sources need to be prioritized for overall success. Value-based purchasing is the system of improving performance of organizations versus sheer numbers. A balanced budget. I use the term no money, no mission. And that's what we use to help the staff understand the importance of keeping a high occupancy. Staff in this industry work hard and may not receive adequate recognition. However, a balanced budget will allow for well-deserved annual raises or even mid-year raises, depending on staff performance. Staff should always have a reason to keep working hard and being engaged. For some, money may be the reason, and others it may be the fulfillment gained from helping others. Either way, money helps build the facility to support all residents and staff functions. On that note, it's important to recognize the staff on a daily basis. So recognitions events like pizza, ice cream, bonuses, they all take financial resources. Finally, a facility might be a for-profit with investors holding a percentage of company shares. Like any investor group, they will expect a high return on their investment. Without an investor's support, it may be difficult for the company to continue growing. That again goes back to the concept of no money, no mission. Income and occupancy, they're sort of interchangeable. Even being below census by 10% could adversely affect income and staffing. For assisted living, the focus remains on those residents who can pay privately. Elderly waiver may only cover 80% of the cost of care. Even so, when occupancy is low, a facility may find it more beneficial to get residents in the door and fill the beds despite the payer source. In the skilled nursing setting, the focus tends to be on the high acuity short-term stay residents. Reimbursement tends to be the highest towards the beginning of the stay, and that's just under the patient-driven payment care model. Payer mix. Medical insurance plans have different reimbursement rates. Certain insurance plans pay so poorly that they simply are not accepted. For example, as a former skilled nursing director, I frequently attempted to get residents to the dentist for preventative care who may not have been there for years. The only problem is that when a resident is covered in a nursing home under medical assistance, then the payer source tends to be South Country Health Alliance. Dentist's office either had too many patients under this coverage and had to put the patient on a waiting list, or they would not accept it at all. I had always viewed this as unfair to the most vulnerable who need preventative care just as much as the next person who needs high quality dental insurance. In the same way, some facilities place potential assisted living residents on a waiting list due to their elderly waiver status. Many of the facility apartments lay vacant as they wait for potential private pay clients. It's my hope that the federal government takes a hard look at payer sources in the future and makes them more competitive to opening the housing resources to more elderly clients. Value-based purchasing is a new reimbursement model for hospitals. Skilled nursing facilities also need to follow a value-based approach known as the patient-driven payment model. The goal is to put measures in place to force healthcare facilities to focus on quality rather than quantity. No longer can a hospital push through multiple procedures a day without weighing the risk of rehospitalization. A quality job must be done, and outcomes are monitored closely. The overall patient care experience is also judged and factored into this reimbursement. Patients can expect better care and experience as a result of this. Regulatory bodies. So the assisted living setting in Minnesota must respond to one main regulatory body, and that's the Minnesota Department of Health. In skilled nursing, CMS regulates Medicare dollars, which governs that body. In assisted living, the Department of Health completes regulatory surveys at least every 24 months, complaint investigations that might be submitted by residents, family members, or even the facility. They update facilities with new regulations as they occur. The mission, as they state, is to protect, maintain, and improve the health of Minnesotans receiving assisted living settings. That's by the Minnesota Department of Health. Regulatory and complaint surveys occur through separate departments within the Department of Health. For example, complaints go through the Office for Facility Complaints, also known as OHFC. The Department of Health can levy sanctions against facilities if necessary. For example, a high-level tag resulting in substantial harm will result in a large fine and a plan of correction. And both the administrator and the nursing director would need to be reported to their own licensing boards. To top all this off, surveys are public documents, and any poor results come with a great deal of embarrassment if the survey goes poorly. What is the director's role in the regulatory process? Well, I play an essential role in holding the facility to a high regulatory standard as required by law. Directors audit for compliance. So, for example, making sure medications are labeled, resident dignity concerns are being addressed, keeping up with service agreements, annual orders. We must adhere to a budget. The acuity and staffing is important. That must be regulated accordingly. As nurses and administrators, we understand patient care and advocate for our residents and clients. Further, it's our responsibility to develop and coach our staff to success. The director is also the educator, staff development, nurse, and discipliner. What is the director's role in the regulatory process? Directors must bring a facility back into compliance when citations result. The director will work with the administrator and staff development nurse to develop a plan of correction to submit to the state. They must also be accountable for other staff members' actions as they occur. For example, a case of abuse or neglect, the director would be tasked with reporting the occurrence to the state. In Minnesota, we use the MARC system, the Minnesota Adult Abuse Reporting System. There are regulatory standards directors must personally hold to. For example, a nursing director shouldn't date staff members or become really close with their employees. They must not be afraid to take action against their own staff to ensure the residents are the primary concern. When taking accountability for legal compliance of facility and personal life, there's always the risk of being reported to the Board of Nursing and then responding to those allegations as appropriate or as asked. In conclusion, these are the main points listed below. Assisted living clients are private pay or elderly waiver. Clients are affected by costs associated with staffing, supplies, and insurance. The Affordable Care Act has raised healthcare standards by focusing on performance versus volume. Staff must understand how budgets and payer sources impact their roles, patient care and paychecks. And regulators are the checks and balances that ensure facilities are taking proper care of their residents. And directors play a huge role in that responsibility. Thank you for taking part in this presentation. The next 3 slides are all about references.